Good afternoon to the audience. Thank you for staying to this late hour of the day. We know you are all tired, so please just bear with my last talk. I'm sorry, I have a bad cough, so please excuse me if I get interrupted from time to time. So the topic assigned to me is antibiotic prophylaxis, use and abuse. By definition, antibiotic prophylaxis is prevention of disease by administration of an antimicrobial agent. It is given to an individual who is at risk of developing an infection because of exposure or an impairment of host defense. So two situations where we are justified in giving antibiotic prophylaxis. It does not apply to those situations in which infection is already established. So when you have an infection, it's no longer defined as prophylaxis. I think it's quite clear. Are we allowed to do antibiotic prophylaxis in all situations? Of course, the answer there is no. It is only justified by the severe consequences of possible infection, as in cases of endocarditis after dental procedures or infections of a surgical prosthesis. The recommendations for antibiotic prophylaxis are not the same in all areas at all times. And it is very important to remember that these recommendations may change periodically on the basis of evolving knowledge, changing pathogens, and the susceptibility to antimicrobial agents. Infectious disease change over time, and what the prevalent pathogens in the past decades may not be the prevalent pathogens in the subsequent decades. There are several criteria for effective antimicrobial prophylaxis. The first would be the antimicrobial drug or drugs used for prophylaxis must have activity against the likely infectious agent or must disrupt pathogenesis, as in the prevention of toxin production. So the prophylactic agent must stop the transmission of disease. Number two, the host should have a defined and finite risk of disease. So you might have heard that we don't give prophylaxis to every person in the community when there are cases of meningococcemia. There are only situations where these prophylactic agents are administered. An assessment to determine the risk is multifactorial, taking into account both the incidence and severity of infection, if it occurs, and the communicability of the agent. So there are agents where prophylaxis is necessary. There are agents where prophylaxis is not necessary. Third, the safety of a chemoprophylactic agent must be such that complications of its administration do not outweigh the risks of infection, or the so-called unacceptable risk-to-benefit ratio. Fourth, the chemoprophylactic agent must have been taken or given, and adequate tissue concentration must be present at the time of exposure to the infectious agent. This criterion is most applicable to antibiotic prophylaxis in surgical procedures. And as I will demonstrate to you, we just don't give antibiotics at any time at the whim of the doctor, when giving it for prophylaxis of a surgical procedure. So the lecture outline will cover three areas of chemoprophylaxis. One is in healthy children. Two is in children with conditions with predisposing to infections. And three, chemoprophylaxis for surgical procedures and trauma. Actually, the third Roman numeral still is under the category of chemoprophylaxis for healthy children, but I just separated it because there are distinct recommendations for surgical prophylaxis. So that is what I was mentioning. Chemoprophylaxis in healthy children are for surgical infections, and to prevent and to be given to children with exposure to agents causing septicemia, meningitis, and other infections with significant morbidity. I cannot mention all the disease conditions where chemoprophylaxis can be given, but I just chose the most common conditions. These include Neisseria meningitidis, Haemophilus influenza type B, Group B streptococcus, human immunodeficiency virus, and respiratory tract pathogens such as MTB and Bordetella pertussis. For Neisseria meningitidis, the recommended antibiotic prophylaxis are either rifampicin or ceftriaxone for children and ciprofloxacin for children for patients greater than or equal to 18 years of age. As you can see, because it's a prophylactic agent, the duration of administration is limited. It's at most 2 to 4 days for Neisseria meningitidis. Why is prophylaxis essential for Neisseria meningitidis? It is because the reported secondary attack rates among household contacts of index cases range from 0.25% in adults to 10% for infants younger than 1 year. So there's a significant difference in disease incidence after exposure of infants compared to adults. Penicillin has been proven to be an ineffective prophylactic agent, and therefore it is not considered as the antibiotic prophylaxis of choice. As I said, it is rifampicin, which is effective in eliminating nasopharyngeal carriage of Neisseria meningitidis when given in a standard 2 to 4 day regimen. When do we start prophylaxis for meningococcal infection? It should be instituted as soon as possible, preferably within 24 hours for contacts in households and child care centers, and sometimes for school contacts, as well as persons who have had contact with infected oral secretions. So the sooner it is started, the better. The alternative drugs are ceftriaxone. However, this is parenteral and, of course, more expensive, and fluoroquinolones are contraindicated in pregnant women and prepubertal children. For Haemophilus influenzae type B, again, the same prophylactic agent is recommended, again for a short period of time, at most 4 days. Rifampicin is 95% effective in eradicating, again, nasopharyngeal carriage of Hib in children. Take note that this is only for type B, and since we know that there are different types of Haemophilus influenzae, we are not sure whether this drug will be effective for other types. Prophylaxis is indicated in an incompletely immunized child younger than 4 years who has had close exposure to a case of invasive Haemophilus disease. As I mentioned, the effectiveness or efficacy of this antibiotic as prophylaxis for other types has not been evaluated. There are 2 indications for prophylaxis for Hib. One is when there are 2 or more cases of Hib disease which have occurred within a 60-day period. So if there are many cases within a 2-month period, then there is an indication for prophylaxis. Second is when there is an incompletely immunized child younger than 4 years who has been exposed. The third agent for prophylaxis is against group B strep, where penicillin or ampicillin can be given. However, this is not given to the child. This is given to the mother. There might be some confusion here, no? It is the mother who is given the antibiotic. It is given at 2 grams initially, intrapartum, and then at 1 gram IV every 4 hours until delivery. So this is started as soon as the mother is admitted near delivery time. So administration of this prophylactic agent prevents early onset neonatal sepsis, not late onset. For HIV, there have been studies which document the efficacy of Cidovudin, 100 milligrams 5 times a day, administered to mothers during pregnancy, with continued treatment of infants at 2 milligrams per kilo orally for 6 weeks after delivery. According to studies, this manner of prophylaxis prevents perinatal or intrauterine transmission of HIV. And studies have shown that Cidovudin reduced the rate of HIV transmission to the infant from 25.5% to 8.3%. So it's now a standard recommendation for pregnant women infected with HIV. On another aspect, Cidovudin also has been shown to be effective when administered within 12 to 24 hours after occupational exposure. So this is not for the baby. This is for an adult who had exposure to a patient infected with HIV. If the exposed person might want to be protected, then he can take cytobutene as a protective drug. For respiratory tract pathogens, we all know that isoniazid is effective in preventing MTB infections in uninfected individuals. So this has to be clear. The patient has to be uninfected at the time of prophylaxis. On the other hand, for Bordetella pertussis, macrolides consisting of either azithromycin of 5 days, clarithromycin of 7 days, or erythromycin of 14 days are effective in preventing transmission of Bordetella pertussis in household contacts if given prior to onset of symptoms. For influenza, well, we just heard the lectures on influenza, and we all know that the best prophylaxis against influenza is through immunization. However, there are situations where prophylactic antibiotics, such as amantadine and rimantadine, amantadine or rimantadine, are effective as prophylaxis against influenza A in high-risk children 12 months and older during an epidemic season, or until immunizations can be completed. Whereas neuraminidase inhibitors such as zanamivir and oseltamivir can be used for other types of influenzae for children older than 1 year of age. Now we go to the next category of children who can be given chemoprophylaxis. These are children with conditions predisposing to infection. These are groups of children defined as immunodeficient or with underlying anatomic defects. Prophylaxis is required over a prolonged period of risk, and strict compliance with regimens is critical to preventing breakthrough infections. So this group of children require continuous prophylaxis. Once the chemoprophylaxis is stopped, then there may be so-called breakthrough infections. These are examples of this group. You have prior rheumatic fever, you have asplenia, you have other underlying conditions, patients with recurrent otitis media, recurrent urinary tract infections, and patients with cardiac abnormalities. For the first disease condition, which is prior rheumatic fever, we all know the prophylactic agents of choice, mainly benzathine, penicillin, Pen-V, or sulfasalazole. These are given to patients with well-documented history of acute rheumatic fever who should receive continuous antibiotic prophylaxis to prevent recurrent attacks associated with either symptomatic or asymptomatic infection. The current minimum duration of prophylaxis is for 5 years, or until the patient is 21 years of age. For those without carditis. For patients with carditis but without residual heart disease, the duration of prophylaxis is extended to 10 years, or until adulthood. For patients with carditis and residual heart disease, then prophylaxis is lifelong, or approximately more than 40 years, approximately until the patient dies. So in asplenia, the antibiotic prophylaxis of choice is penicillin V. These are asplenic children are children asplenic children with malignancy, thalassemia, other congenital anomalies and diseases with high risk of fulminant infection should receive chemoprophylaxis. However, the recommendations for chemoprophylaxis in children who undergo splenectomy for trauma is not yet sure. The better manner of prophylaxis is through immunizations by giving pneumococcal, meningococcal, or Hib vaccines. However, if these are not administered, then chemoprophylactic agent may be administered. For recurrent otitis media, there are 3 options: sulfasalazole, amoxicillin, which is given at 20 milligrams per kilo for 3 to 6 months, or amoxicillin at a higher dose, 40 milligrams per kilo per day in 3 divided doses at onset of URTI for 3 to 5 days. These are given for children who experienced 3 episodes of acute otitis media within the previous 6 months, or 4 episodes within the previous 12 months. So not any patient with acute otitis media should be given prophylaxis. And there are studies which show that continued prophylaxis is more effective than intermittent prophylaxis. For recurrent UTI, the usual recommended drug is trimethoprim sulfamethoxazole or nitrofurantoin, indicated in the following situations: children with underlying anatomic or neurologic lesions leading to a higher risk of infection, especially those with obstructive lesions or vesicoureteral reflux, or children without identifiable risk factors who suffer recurrent infections, which is defined as 3 or more UTIs within a 1-year period. Now, the last group of children with predisposing infections for which chemoprophylaxis should be given are patients with cardiac abnormalities. There are certain cardiac conditions which have been identified with highest risk of adverse outcomes from endocarditis, for which prophylaxis for dental procedures is recommended. These are the following: patients with prosthetic cardiac valves, patients with previous infective endocarditis, patients with congenital heart disease, but not all. These are only patients with CHDs who are unrepaired cyanotic, including those with palliative shunts and conduits. CHDs which are completely repaired with prosthetic material or device, whether by surgery or by catheter intervention during the first 6 months of the procedure. And lastly, CHDs which have been repaired with residual defects at the site or adjacent to the site of a prosthetic patch or prosthetic device which inhibit endothelialization. The last group will be cardiac transplantation, in which cardiac valvulopathy has developed. What are the dental procedures for which endocarditis prophylaxis is recommended? According to references, these are dental procedures that involve manipulation of gingival tissue or the periapical region of the teeth, or perforation of the oral mucosa, such as in professional cleaning with gingival probing. I don't know what that means, gingival probing. So alam ko lang cleaning. Gingival probing, I don't know. We have to verify that with the dentist. Biopsies, suture removal, placement of orthodontic bands. So these are the various regimens for prophylaxis for dental, oral, or upper respiratory tract procedures. You have amoxicillin given once 30 to 60 minutes prior to the procedure, or clindamycin for pen allergic patients. IV medicines for patients who cannot tolerate oral drugs can be in the form of ampicillin, azithromycin, or clarithromycin. Now we go to prophylaxis for surgical procedures. It has been established that antimicrobial prophylaxis reduces the incidence of wound infections after certain operations. However, it is only indicated when the benefits of preventing wound infection outweigh the risks of potential adverse effects of the prophylactic regimen, emergence of resistant bacteria, drug interaction, superinfection, and cost. We know that antibiotics cost money, and it is only when the risk-benefit ratio is favorable that these are administered. There are only selected surgical procedures for which antimicrobial prophylaxis should be given, and these are procedures with high infectious rates, which are: 1, procedures involving mucosal surfaces, the so-called clean contaminated procedures, those involving implantation of prosthetic material, and those where the consequences of infection is especially serious. Maybe let us refresh the meaning of these types of operative wounds. And in the table, we have the classification of the operative procedure the criteria, and the risk for surgical wound infection. So we say that the operative procedure is clean when it is elective, not emergency, when it is non-traumatic, primarily closed, with no acute inflammation, no break in technique, respiratory, GI, biliary, and GU tracts are not entered. In these types of operative procedures, the risk for surgical infection is very low at less than 2%. And that's the reason why antibiotic prophylaxis is not recommended for clean surgical procedures. For the rest of the classification of operative procedures, antibiotic prophylaxis is recommended. For clean contaminated, these are procedures which are urgent or emergent, otherwise clean. Elective opening of the respiratory, GI, biliary, or GU tract with minimal spill and not infected urine or bile, with minor technique break, where the risk of surgical infection is less than 10%. Contaminated procedures are when the procedure entails has non-purulent inflammation, but there's gross spill from the GI tract. There's entry into the biliary or GU tract in the presence of infection. There's a major break in technique, penetrating trauma less than 4 hours duration, chronic open wounds to be grafted or covered, where the risk of surgical site infection is about 20%. Lastly is the dirty type of operative procedures, where there's purulent inflammation such as abscesses, there is pre-op perforation of the respiratory, GI, or GU tract, there is penetrating trauma more than 4 hours. The risk of infection is about 40%. So what are the surgical procedures for which antibiotic prophylaxis is recommended based on the table previously presented? These are mainly procedures of the biliary tract, the GI tract, gastroduodenal procedures. These are the endoscopic procedures, gynecologic surgery like hysterectomy, CS, and therapeutic abortion, head and neck surgery such as incision through oral and pharyngeal mucosa. In neurosurgery, these are CSF shunt procedures and craniotomies. For orthopedic surgery, open reduction of a fracture, not closed reduction, prosthetic joint replacement, amputation, laminectomy, and spinal fusion. All urologic surgery, and vascular and cardiothoracic surgery. Pulmonary resection, prosthetic valve, CABG, pacemaker or defibrillator implant, cardiac cath, and peripheral vascular surgery. As I said in the earlier slides, the antibiotic of choice depends on a number of factors, one of which is the organisms which are likely to cause the surgical site infection. And this table shows the most common etiologic agents of surgical wound infection by type of procedure. So when you have clean surgery, the usual etiologic agents are Staphylococcus aureus or MRSA, depending on the predominant strain in the institution. So some institutions have low incidence of MRSA, some have high incidence, and therefore the antibiotic prophylactic agent of choice will depend on the rate of MRSA in your institution. For foreign body insertion, the usual etiologic agent is coagulase negative staph. For surgery of the colon, these are gram-negative bacteria and anaerobes. For gynecologic surgery, it's gram-negative bacteria and beta strep. For genitourinary surgery, it's gram-negative bacteria. And for head and neck surgery, oral anaerobes and other normal oral flora. We next go to the other criteria for selecting chemoprophylactic agent, which is timing. This is where a lot of inappropriate use of antibiotics for surgical prophylaxis occurs. Some patients, as they enter the hospital, get antibiotics 5 days, 3 days before the operative procedure and continue on until discharge. This is actually not prophylaxis anymore, but more like therapeutic than prophylactic. So antibiotics must be given so that good tissue levels are present at the time of the procedure and for the first 3 to 4 hours after the surgical incision. The optimal time to give an antibiotic is 30 to 60 minutes before the incision is made. usually at induction of anesthesia. For CS, there is a delay of antibiotic administration until the umbilical cord is clamped. A single dose is usually sufficient in most instances. For prosthetic device insertion, prophylaxis duration can extend up to 48 hours. If the procedure lasts several hours, then a redosing is suggested because there are certain operative procedures which last for more than 12 hours. What are the antibiotic choices? Cefazolin is favored for most surgical procedures. So let us just recall what types of antibiotics we give to our patients who are pre-op. Because it is more effective against Staph aureus than the newer cephalosporins and less expensive. It does not suppress all bacteria and has a moderately long serum half-life. Other possible choices are cefotetan or metronidazole gentamicin for colorectal surgery and appendectomy because of its additional activity against bowel anaerobes, of course due to metronidazole. Vancomycin is used for anti-staph activity if the patient is allergic to cephalosporins or MRSA is a major hospital pathogen and prosthetic devices are being inserted. I was also asked to discuss not only the use of chemoprophylaxis but the abuse aspect. I will not dwell too long on this as we have shortage of time. So we just have 2 slides on this. In studies abroad, in Utah, for example, in the peer review of evaluating 21 hospitals in 1980, there were about 4,753 days of use of prophylactic antibiotics. Only 3,789 were considered 3,789 were considered excessive. In another survey in the same state, a few years later, more than half of overall use of antibiotics was inappropriate, and 78% of inappropriate use involved antimicrobial prophylaxis in surgery. You may be wondering what the local situation is. For the next 3 references, I decided not to mention the actual hospitals, but you can ask me later. So in local publications, the first one was by Dumo. In 1995, 89.4% of prophylactic antibiotic used for surgical procedures were inappropriate in a big private hospital in Quezon City. In another study, 7 years later by Mati, 83.7% of 86 cases were given inappropriate antibiotic prophylaxis for elective surgical procedures at a university hospital in Manila. And lastly, in a study by Flores in 2004, 92%, almost 100%, of surgical cases in a tertiary care government hospital in Quezon City were given inappropriate antibiotic prophylaxis. You may ask what the criteria were for deciding appropriateness or inappropriateness of prophylaxis. In one study, they asked the consultants of the infectious disease service to assess whether prophylaxis was appropriate or not. In another study, they compared the actual practice with the guidelines of the Philippine College of Surgeons, which was released in 2001. So the local surgical society has its recommendations. However, as we have seen, these are not followed in many places. The Society of Healthcare Epidemiology of America, or SHEA, and the Infectious Disease Society of America, or IDSA, have given recommendations on strategies to prevent surgical site infections in acute care hospitals. And these are the following. We administer it only when indicated. We administer it within 1 hour before incision to maximize tissue concentration. And the choice will, we should select the appropriate agents on the basis of the type of surgical procedure, the most common pathogens causing SSI for a specific procedure, and published recommendations. The duration of therapy should be within 24 hours for most procedures, except cardiac surgery, where prophylaxis should be stopped within 48 hours. The same societies also recommended prevention and monitoring strategies, and these are the following. We measure and provide feedback to providers on the rates of compliance with process measures for preventing and monitoring SSIs, including antimicrobial prophylaxis. However, in many hospitals, I doubt if this is actually done, because this process takes time and effort, usually on the part of the infection control nurse or the infection control physician. Second is to educate the surgeons about SSI prevention. Well, we see that the Philippine College of Surgeons has its own recommendations and is probably conscious about the need for judiciously recommending antibiotic prophylaxis. Thirdly, the hospital senior management should be made responsible for ensuring that healthcare system supports an infection prevention and control program that effectively prevents occurrence of SSIs. I think that's the last slide. Thank you very much.